All right, we're going to kick off. We're going to be talking today about hypogonadism, low testosterone, hot topic for all of us, I think, in our primary care practices. And so I think most people probably know Jake, Dr. Fantis, one of our urologists here, assistant professor in urology, who does a lot of work in men's health, infertility, et cetera. So he did his medical school at Baylor, did a urology residency at the University of Chicago, and then did a clinical fellowship at Northwestern on infertility, andrology, and sexual medicine, and has really kind of established himself here at KU as a great educator. I know he's very popular amongst the medical students, and also quite a prolific researcher, 50 peer-reviewed journal articles at least. So we have an excellent expert with us here today to talk all things low testosterone. So thanks, Jake.
Yeah, thanks for having me.
Cool. So we'll kick off. So this is kind of almost in like a series of reproductive endocrine abnormalities. And so we have several things coming up. So we're doing hypogonadism today. In a few months, we have someone called Jewel Kling coming in and talking to us about basically like TikTok, Instagram, hormonal therapies and kind of the evidence for and against them and stuff like that. And then after that, we're talking about perimenopausal. So this is something that we're hitting really heavily because it's getting a ton of traction over social media, and we're getting a ton of questions about it. And so we're starting with hypogonadism primary care. I think we've had an endocrinologist come and talk to us about it before, and I figured let's get a different opinion, and we're bringing in a urologist, and so we're very excited. So the objectives are to discuss signs and symptoms that should prompt evaluation for hypogonadism, discussing the workup for primary versus secondary, understanding how to appropriately counsel a patient on the risks and benefits of testosterone supplementation, and then discussing therapies for hypogonadism and recommended follow-up. And already practice changing. Jake, before we even started, already gave a pearl. And so, I mean, that's already practice changing for me. So I'm really excited. So let's talk about the basics and talk about kind of like the big trials that really looked at testosterone use. And if Dr. Fantis, if you just want to give us a general overview and kind of start there, that'd be awesome.
Sure. Yeah, these are probably the biggest landmark studies in the last decade or so, and there are a number of papers from each of these really looking at both the therapeutic use of testosterone and what it treats, and then as well as like potential adverse effects of testosterone. I think it's important to first kind of understand the patient populations that are in each of these. When we talk about like the T trials, these are usually elderly men greater than the age of 65. It's also important to understand what their threshold for treatment was. To digress just for a second, you can go to any different guideline, either urologic or endocrinology, either in the U.S. or in Europe, and you're gonna get a bunch of different thresholds for treatment. Admittedly, I do practice urology, so I follow the American Urological Association guidelines, which use 300 nanograms per deciliter on 2 morning samples, plus some degree of symptoms being the definition for testosterone deficiency. But all these trials are designed a little bit differently. So again, T trials, men over the age of 65, levels that were pretty low, less than 275, and they did have some degree of symptoms. They were treated with gels, and again, we'll talk about this later. There are a lot of different formulations to replace testosterone, but it's very important that you can't necessarily generalize all the findings from one specific formulation to another just because they act differently. When we talk about gels, there are things that go on over several hours and then wean throughout the day and are dosed daily, compared to things like intramuscular injections, which it sounds like you guys are used to, where the most frequent dosing is every other week, meaning instead of getting these small peaks and troughs, you're getting these large peaks, and those peak levels are usually what's responsible for some degree of the side effects. So, just remember that take every trial with a grain of salt with regard of what formulation was used and what kind of levels were achieved. So again, T trials, elderly men, gels, people with pretty low testosterone, 275 and below, and symptoms. And things that, I think are important takeaways from that one specifically is that most of the improvements they saw were sexual, that people had increased sexual desire, that people had potentially better erections, but usually in tandem with an oral medication. That's a big sticking point in the American Urological Association guidelines, is that testosterone under most circumstances should not be given for monotherapy for erectile dysfunction, but definitely is something that can treat people with decreased sex drive if it's pathologically low. But that was one of the big findings from that. They also found that men that were more feeble, that were given testosterone, had improvement in some of their exercise capacity, but men who have normal activity levels, even with low testosterone, didn't necessarily improve. So when I'm counseling patients on this data, especially men that are over the age of 65, usually I say that your physical stamina may improve slightly in some patients, but not in everyone. But for people who are relatively deconditioned, it does seem to be independently more beneficial. Besides that, things you would expect to increase because you're increasing testosterone. We talked about polycythemia, but that also means people with like unexplained anemia or decreased red blood cell count did show independent benefits from this. Bone health, as some of this is converted to estrogen, people did improve their DEXA scores. Cognitive findings, again, in this population were pretty mixed. I'm sure you guys get a lot of patients coming in talking about brain fog and thought processes, etc. Findings from this are pretty much equivocal. I do think it helps some patients anecdotally, but I certainly would not, when I'm counseling people, say, hey, this is going to help X. I'd say there are some studies that show it does and others that show it doesn't. And the T trials are a pretty good example of that. Also showed importantly that there's an increase in lean mass, decrease in fat mass. This is going to be true across all of these trials. And that's been true for a long time. We do know it affects lean body mass significantly. Most people will come and complain they haven't lost weight. It's usually a trade that they tend to get an increased amount of muscle and lose fat at the same time. Beyond the scope of this, there are some really interesting trials from the 90s where people were just given a ton of testosterone. This is trial that Senator Boston actually is at Brigham now, gave people 600 milligrams IM testosterone every other week and randomized that to placebo and then randomized people to exercise program versus no exercise program. And interestingly, the second most improvement to the 600 plus exercise was the 600 without exercise. So there clearly is a extreme metabolic signal, especially at higher levels of testosterone. One of the other takeaways from the T trials is actually that they, had done some cardiac coronary scans and found an increase in non-calcified plaque in patients. This is post this, 2014 box warning on testosterone. So there's all this concern that testosterone could be increasing, intimal thickness and possible cardiovascular morbidity or mortality. But if you look at the total number of patients, there were less than 1,000. I want to say it was like 750, 790, somewhere around there. And it clearly was underpowered to show any differences in cardiovascular morbidity. The only trial that had a major difference, and it was after statistical modeling, was that Vinian paper, which a lot of the fear for replacing testosterone was based on. We'll go to the T4DM, and we're going to do this in chronological order. That was, I want to say, right around 2020, 2021. It was similar size, about 1,000 people. The men were a little bit younger to a little bit older. I want to say it was like a 50-year-old or older. Their threshold to treat, though, was different. So these are all pre-diabetic men, and their threshold to treat was testosterone of less than 400, and people who had, pre-diabetes. So again, this is a very different patient population. The biggest problem I have with this trial is they used a product which we don't use here. I'm not aware because I tried to get it here. It's called a VEED, where it's a long-acting testosterone undecanoate that is put into the muscle and is designed to last for 10 to 12 weeks at a time. One of the complications of this is these microemboli people can have. They need to be watched in the office for 45 minutes to an hour afterwards. And for that reason, pharmacy here, at least at the Maine and Indian Creek, we're not comfortable getting this. So because this acts so differently, I'm a little bit cautious interpreting any of the findings because we don't use this formulation. It's widely prevalent in Europe, but if you look at the prevalence across the United States, it's not reimbursed well, so private practices are not using it. The bill and buy is not very high, so there really isn't a motivation other than trying to dose people less frequently. And most people in that category end up with pellets, which we can talk about later if you're interested. But the findings of this were basically that there may be some improvement in metabolic signaling, some improvement in insulin sensitivity in the pre-diabetic population. Everyone was also combined with lifestyle modifications, though. So it's a little bit difficult to tell if there's going to be an independent effect of the testosterone versus lifestyle. I mean, they did show it in the study in men with diabetes, but in men with pre-diabetes, the lag time to developing diabetes was greater in the testosterone group. Again, not sure too much what to make of this, just because I don't know about all of you, but I don't treat people with testosterone of 395 with testosterone therapy, let alone this specific formulation. I think the single biggest trial is the Traverse trial. So this trial, unlike the other ones that were looking for the efficacy of testosterone, was looking for the safety. This was actually mandated by the FDA for the safety. They had Endo, AstraZeneca, all the major pharmaceutical industries that had any bind to testosterone come together and sponsor this trial. They paid for it, paid a third party to do all the data collection, analysis, etc. So even though it is industry sponsored in the sense that the funding came from industry, all the funding was delegated to a third party to conduct the research in earnest. Big takeaway from this, these are all men 45 to about 80 that were at higher risk for cardiovascular disease, either previous MI, high, CHA2DS2-VASc score, something that would put them at risk. Otherwise, this would not have been appropriately powered to detect a difference. So there's a box warning on something, and the power, literally, there's 5,500 patients in this study to find this difference. So the difference to begin with for heart attack and stroke was not so big that they could do that was 1,000 patients. So massive study. Median follow-up was a little over 2 years. So they did follow these patients up longer than any of the other studies. Their definition of testosterone deficiency is similar to what the AUA uses, meaning less than 300 on 2 samples plus symptoms. They used gels. Again, that's my one caveat here. These are gels. And the other caveat is if you start looking in the weeds and the data, you actually can see that their average level in the replaced population was, between 350 and 750 with a median of 432. If you look at the data when we talk about replacing, a lot of times we're saying to replace to 450 to 600. So we wouldn't necessarily even consider these people adequately replaced. So to rephrase that, we have an enriched population to look for potential cardiovascular morbidity and mortality, but we dose them with gels only and likely at a dose lower than what we are going to end up giving patients or what we're going to see. So that is a big takeaway here, is that when we talk about the relative safety, it seems safe, but is not fully generalizable to all the stuff that we necessarily do. Looking at the data, there were no increased risks of heart attack or stroke. There was no increased risk of thromboembolic events. Again, going to the weeds, there was they didn't measure it, and they said because it was a tertiary endpoint, it wasn't pre-powered for, there was a slightly increased potential risk of pulmonary embolus independent, very small risk. And if you look at some of the sub-analysis, people really talk about maybe having a separate conversation with people who have a hypercoagulable state. I do this in my practice. If somebody comes in, has Leiden factor 5 or something else going on, I will often tell them, hey, there may be a slight increased risk of DVT, PE, etc. I can't tell you. That's never been quantified, but just so we're on the same page, this is a potential risk. Other risks for this were AFib, AKI, things that I think they're pretty small, weren't powered to show them either. The AKI, I think, is probably just a misnomer of people having more muscle mass and their creatines going up as a reflection of that. There have been subsequent, papers basically saying that. Other fallouts of this study, there was a paper that was published, I want to say in JAMA, looking at increased fracture rates in people with testosterone therapy. Again, this is not a patient population that was randomized or predetermined. It's impossible to know what their pre-DEXA scans were or risk factors for osteopenia or osteoporosis are. I rarely tell patients there's an increased risk. I mean, every other paper has shown a decreased risk and improved bone health with testosterone therapy. So I think more, research is needed in that specific space. And the last thing I think is important, being a urologist, is how does testosterone affect the prostate? There's a paper looking at testosterone and prostate-related events as a fallout of this trial, both prostate cancer and BPH related. No increased risk of prostate cancer, no increased risk of biopsy, no increased risk of urinary retention or complaints or starting new medications for urination. So in people that are appropriately chosen for therapy, I know endocrine and urology have a pretty different opinion here, but I'm never telling people that they're going to get BPH-related symptoms while they're adequately replaced. Now, there are 2 caveats to that. Number one is that people who have had castrate levels of testosterone, which again, I presume this will either be in my clinic or an endocrinologist clinic, those people, if they, didn't go through puberty or went through puberty and then have had very low levels since, those people may end up with more urinary symptoms because they've had no stimulation to their prostate whatsoever. There's a theory that came out in 2010 by Abe Morgenthaler talking about saturation of the androgen receptors in the prostate. And basically, if somebody has such a low amount, the prostate will grow quite a bit based on the testosterone levels. But if they have a low level amount, they have a low level, 200, 170, it's unlikely that the prostate is going to grow much based on that alone. Now, there will be increased cell turnover, and all these studies show that. And what does that translate to is more PSA. So if you start testosterone, I would expect to see a slight increase in PSA. And the way I like to think about this is your PSA doesn't go like this. Your PSA trajectory was like this. You start testosterone, it goes up, and then it goes back on that same slope that it was on before. So you should see a small rise due to that, and that rise should have been stable, and the slope after 6, 12, 18, 24 months should be similar. If you start seeing this, that would be the sign of a potentially missed prostate cancer. Please refer them to our clinic. So again, major positive findings, things we know, testosterone is great for sexual symptoms, specifically low libido, erectile dysfunction with a phosphodiesterase inhibitor like Cialis or Viagra. It's good for increasing bone health, with the exception of that one study I mentioned, increasing skeletal muscle, decreasing visceral adiposity. Things that we don't know are, again, its effects on somebody's insulin resistance. Energy is the biggest one. Some people really improve with their energy. Those people tend to be the people with those really low levels. But anybody that comes in, I say there's a 50-50 chance it's going to help you. And if it's not helping you when we put you on a trial for 3 to 6 months, the answer is not your testosterone. Your fatigue is either age-related or due to something else. Sorry, I know it was a really long diatribe. I apologize.
Nope, that's what we're looking for. I mean, I guess one question I have for these studies is are these patients being put in there when you're evaluating for prostate cancer? Did they exclude patients who are high risk for prostate cancer, patients with like known BRCA mutations or family history?
Yeah, PSAs in most of these were like less than 1.5 or 2, have never had a biopsy, don't have urinary symptoms. Most of these people were heavily screened. That's a great question. Heavily screened to not have urinary issues or prostate cancer.
Cool. All right. Let's jump in. We have so much to go over. There is no way we get to everything, and that's completely fine. So, general case, this is about the most average case I could possibly come up with. So, 57-year-old comes into your clinic saying his energy isn't what it used to be and is wondering if you can check his testosterone. He has a lot of friends who have seen doctors online, and their testosterone is now better than an 18-year-old. He says his sex drive isn't what it used to be and feels like he just doesn't gain muscle as easily anymore. So this is a common scenario that we run into where people just come in and they're like, hey, you mind throwing on a testosterone? Kind of, I guess, what do you do in that scenario? And what is the scenario when someone comes in with symptoms where you say, we should probably check his testosterone in you?
Yeah, I mean, this is obviously, I think, become much more common with all the direct-to-consumer advertising for, testosterone. Two things. Number one, if somebody is curious about their testosterone, I usually go, well, why do you think you have a low testosterone? What symptoms are you manifesting? Typically, I don't want to prime them and ask them why they're, what the symptoms are. I'm just curious why they think they need it. Most common one is low energy, and being the most non-specific symptom ever is very easy that anybody would check that box just because they had a stressful job or some, home life issues. But if it starts becoming more specific, like, yeah, I just like I don't find my partner physically attractive. I'm not interested in sex. I feel like I go to the gym 5 days a week and I've been getting weaker or things of that nature. That definitely would make me more inclined to check a testosterone level. At the end of the day, I don't think it's, all of us are trying to treat the patient. Most of us probably succumb and say, okay, we'll check it and see what it is and then go from there. I get the reality here. I mean, I do the same thing. Usually it's with a caveat being like, hey, you don't really have any symptoms, so we're going to get this number back, but we're just going to watch it. I don't have a reason to necessarily treat you without any kind of symptoms. But again, that fatigue one is just, fairly ubiquitous. Reasons why you should check a testosterone in somebody that doesn't otherwise complain of wanting it checked. Erectile dysfunction, especially nuance that without a good reason. 45-year-old comes in, clearly their lipid panel looks good. They're not on any new antihypertensives. They're fairly fit, and all of a sudden they're like, yeah, just things aren't working as well. That would be the indication that maybe there is some endocrine abnormality. Now, I think you're all here shaking your head, but that's somewhat the rarity. Usually there's some, comorbid, metabolic syndrome that is going on that could likely be treated and improve their erections. But this is a guideline-based thing from the American Urological Associations and the SMSNA. Unexplained anemia, bone health issues that are unexplained, fertility issues in men would be reasons I would get a testosterone level outside of somebody asking. One thing I didn't mention on the trials because it wasn't there is if you come to my clinic, everyone gets screened with both a stopping and a PHQ-2. And I know you guys do all the PHQ questionnaires, but I think it's so important because there's so much comorbidity that can influence both energy levels as well as potentially treatment endpoints here. The amount of people I find with untreated sleep apnea, for example, that have bad energy, and that even influences your endocrine axis. Super important to look for things like that. So sometimes before I'll even check a testosterone, I'll be like, your stopping's 7. Maybe we should talk about getting a sleep study before we kind of go down this pathway.
It's interesting because like you're checking in the context of ED, but when we were talking about the trials, we said, oh, when you replace with testosterone, it doesn't necessarily get better if you're not using an oral supplement for this.
Correct. And I wouldn't necessarily give somebody testosterone and say, hey, this is going to make your erections better. We probably will need to do more than one thing. And in fact, actually, one of my favorite pieces of literature is the Canadian guidelines for testosterone replacement, the Canadian Urological Association, because the way it's written is a for or against replacing testosterone for every single potential symptom someone has. And for erectile dysfunction, you could just argue, we could just treat this. And that was usually what I'll do. Let's say their testosterone comes back at 250. It's like, hey, well, you could be on 2 medications or just 1 medication. Let's see how that works. Oftentimes, people are inclined to take a pill rather than inject themselves or put a gel on. Sometimes it doesn't work as well because of that. And then sometimes like, you know what? Actually, it's not just my erections. I actually am having problems with sex drive. I actually am having these other problems in other areas in my life. So that conversation can go one of many different ways.
You already mentioned that you're checking twice on patients. And actually, I think that the cutoff is kind of a big deal because I feel like a lot of patients live in the 280 range. And so it depends which guideline you're using, 300 or 270 to determine treatment. I do 270, I think, because I listen to more like endocrine guidelines, and that's what our low comes out as at KU is 270. But I mean, I guess, what are your nuances to that? Do you have them fast? Talk about your first testing.
Uh, so this is actually probably one of my proudest papers, is looking at 200,000 men and just epidemiologically what testosterone levels are in asymptomatic patients. And I think it's fascinating because everyone gets that range back, which was probably one of the best well-designed studies looking at age-adjusted testosterone levels in non-metabolic men. And my manuscript tried to follow that entire thing, looking at both people with and without diseases. But the important thing is not the way that where we got the data from actually had people getting it drawn morning, night, fasting, non-fasting, different times of the year. So we were looking for not only diurnal, but like seasonal variations, fasting-based variations. And because there were so many numbers, we were able to do this. So if you look at all the things, I agree, it should be an AM level, ideally before 10 a.m. if possible. It does not matter whether or not you're a shift worker. I do realize it does mess with your circadian rhythm, but there's a lot of work from Baylor really looking at it. I'd still have them get it before 10 in the morning, just based on light exposure. Um, Fasting, Europeans, very big into this. American Endocrine Society, also big into fasting. We found that fasting made maybe a 10, 15 point difference. I think at some point it's hard enough to get the level in the morning. I tell patients if they fast, great. If not, I don't care. I mean, I don't think it makes that big of a difference. Seasonal variation did not seem to make a difference either, but the diurnal variation is strongest in younger men, especially men under the age of 40. It tends to be blunted as people age. However, if you go to the data for where it's blunted from, that data is also data that suggests there is a massive decrease in testosterone levels by decade of life. Now, there is some truth to that. After the age of 70, we absolutely see a secular decrease with testosterone by decade of life. However, some of the historic cohorts, like the Baltimore Longitudinal Aging Study, have shown that if you segregate men with and without metabolic syndrome, so specifically obesity and the acquisition of diabetes, that men who stay healthy, their testosterone levels seem relatively unchanged. And that's the same thing that the study I did concluded, is that men who stay healthy, their testosterone don't change, and men who have the same comorbidities, their testosterone levels don't change. They just tend to be lower. But if you look at the rate of people developing obesity and diabetes, it increases with age. Therefore, you're seeing the same decrease in testosterone epidemiologically with the acquisition of those comorbidities. So I think it's important to kind of manage both of those things. In terms of a level, I use 300. A lot of the trials beyond what I just discussed that are more historic use 300 as a diagnosis, but it's a population-based data. I don't know. You'll have people that probably their levels need to be above 400. People whose levels don't need to be above 170. The line I draw in the sand, and I think 280 is fine too, is 300. That kind of dovetails nicely into your next question is like, when do I use ancillary testing to maybe change my mind? Typically when it's between 3 and 350, if I'm looking for a reason why this person may not actually benefit from testosterone therapy, most common being somebody who's overweight, who probably has a decreased SHBG level and an increased relative free testosterone level. So somebody, again, I said 3 to 350, it's usually 250 to 350. A person may have a 260 testosterone, but a completely normal free testosterone because they're depleted in SHBG. Endocrinology does this a lot more than we do. I'll tell you, most urologists here do not use free testosterone, but I usually use it as a tiebreaker. And you completely candidly, it's like, I don't think this person is going to benefit. Let me have some evidence to show why they're probably not going to benefit. Or it's somebody who maybe they're at 320 and they look like somebody who may actually benefit. And if I check and their SHBG is elevated, or they have another reason to have a depleted free testosterone, then I would consider them to put them on therapy. And just one more aside, if you're going to order free testosterone, I would do the Mayo send out for equilibrium dialysis. The calculated free testosterone is based on the same inaccuracies of the total testosterone, then based on inaccuracies for albumin and SHBG labs. And I wouldn't make clinical decisions with it.
So is the one at KU
It's not
less
equilibrium
accurate
dialysis.
one?
It's calculated. It's calculated.
Oh. So is there a specific order in the system for this better?
I made a preference list that does a send out test and says send out to, I think Mayo is the only place I'm aware of close it does equilibrium dialysis for this. But yeah, the CDC does it. There are a few places that do it. But if you're going to get in the weeds with this, that would be my recommendation, that the free testosterone here is less accurate. Unless you order an SHBG and you're like, hey, their SHBG is really low. Like, there's a reason for this to be. So sometimes I'll order an SHBG without having to do an expensive send out test. And it does take several days to get back.
Okay.
So probably just for most of our primary, we ought to be total testosterone. Probably ought to be.
I think so. I think if there's questions,
basic primary care type of stuff on that. Can I just ask that? I don't know that I'm still very comfortable diagnosis wise, right? So the level's low, with these symptoms, they're so vague still, right? So fatigue or sex drive, everyone tells me their sex drive's lower than when they're 18. And every man thinks they should be stronger than they are and all that sort of stuff. Like, how do you actually feel like that's really tied to that or not when you're kind of making that diagnosis? Like, can you just give me a little bit more granular detail on that so I feel confident that if I'm diagnosing it, it's truly from this and not just calling
yeah. If you do, please tell me how you make that decision, because I can tell you I do not have that confidence. I mean, this is one of the problems. You have a bunch of non-specific symptoms. And this is actually something I was working on when I was at Northwestern, was trying to create a validated questionnaire. Just so you guys know, there are plenty of questionnaires for low testosterone. None of them have been validated, either in the diagnosis of and or monitoring the treatment of low testosterone. So super important that, putting these points, if you're right, there's not a good way. I think there's a amount of clinical gestalt that goes into it. I think it's actually more important on the back half of the conversation, which is, this is what we're going to do and how we're going to monitor it. And if you don't fall into one of these buckets, then we're done. So normally the speech I give is, we're going to try a trial for 3 to 6 months, and we're going to look at your levels. If we get normal levels and you feel a lot better, then this is clearly, at least in part, what's causing this. If we do not get to a normal level, then we will make sure we adjust the dose, and then we'll give you a fair trial. If we get to a normal level, however, and you feel no different, this is not the reason you're having these symptoms. So unfortunately, the amount of trial and error in this is still way more than I like to admit. But there is quite a bit of that. I think setting those boundaries up at the first meeting with the patient are really important, because I inherit a lot of patients. They're like, yeah, I just felt better when my testosterone was 1200. And usually I have unfortunately, I went on some podcast that says like, yeah, I mean, things, dopamine feels really good, but I wouldn't tell you to take a bunch of drugs to elevate your dopamine. There's actually this thing called a testosterone high. When your testosterone does get so high, there are neurocognitive changes that people do feel euphoric when their testosterone is that high. That does not mean that it's normal and or safe. And again, I have this conversation day one with the patient and set expectations because again, a large degree of this is trial and error.
That's really helpful. And then, yeah, what if I miss this diagnosis, Jake, and they're low testosterone? Like, what are the harms of someone running with truly deficient low testosterone? So there's bone health. I think that one we know. Are there other
Yeah.
big players here that where I need to be a little bit more clued in on this as a diagnosis rather than just kind of ignoring it or dismissing some of those symptoms?
Outside of bone health, potentially unexplained anemia, it really depends on how low it is. I can give you a situation where it could make a difference. If it's somebody who's like 170, 180 or above, these people we see in the 200s, it's very unlikely. I don't have great data to substantiate that, but it's unlikely it's going to make a difference. I did another paper looking at the risk of premature mortality with men with normal and low testosterone, and again, segregated by morbidity. And when we did that, people always say that people with lower testosterone are going to die younger. But when you start controlling for things that directly affect testosterone, you realize that that signal relatively disappears. Not completely, but it disappears relatively so, meaning that I'm not sure you're going to be making a big difference outside of symptom relief. The one exception is people who have like borderline castrate levels. Again, most of these people will be in my clinic because they've had treatment for prostate cancer and they never recovered. Their testosterone is 34. We know people with castrate levels of testosterone have an incredibly high risk for having cardiovascular events. So people that truly have super, super low levels probably would benefit from some form of therapy. The second exception are people that have, again, they'd be primarily close to castrate levels would be people that have something happen, meaning they were normal and then had, bilateral testicular injury, something where they were put into this state of significant abnormality. But the person whose testosterone just slowly drifts due to age and comorbidities, unlikely. It's the people that have like pathologic, like truly pathologic, almost castration that are at risk for something. So those patients I would be scared to miss. Other ones, not as much.
I was listening to a podcast one time and it made me feel a lot better because they basically said like 50% of patients who get put on testosterone in this kind of like no man's land, like 250 to 300 range, like 50% of them will just take themselves off within a year because they won't see any difference at all. Which I was just like, well, that kind of takes my difficult part of my job away. But we have someone that's asking, is this kind of like a diagnosis of exclusion? I do feel like, especially with fatigue, it's like, yeah, I'm doing all this other thing. I'm doing TSH and B12, and I'm checking for sleep apnea and depression. And then if I have a moderately low testosterone, I feel like, yeah, maybe we try treating that and see if it gets better, like you say, a 6-month trial.
Yeah, I mean that is exactly how I approach this. I think with fatigue, it is absolutely a diagnosis of exclusion. If you look at some of the other epidemiological studies, like the Massachusetts male aging study, the most specific symptoms tend to be sexual. Low libido in the correct circumstance tends to be the most specific. Decreased morning erections, erections in general. They have those, and then all of a sudden they're also complaining of fatigue. My sensors go up like, hey, this may be real. When people are just, like, I'm fatigued, I can't build muscle, blah, blah, blah. I've had a good erection in a decade, and they're not kind of coinciding collinearly. I'm like, again, we can try it, but in that case, I feel like it's more of a diagnosis of exclusion.
Okay.
John,
I feel like we
just
yeah,
quick.
sorry, go ahead, Brandon.
So one of the things I learned somewhere along the way, I guess there's this truth or myth, right? So if we start somebody on exogenous testosterone replacement, I think then I was kind of told that your body will not regenerate that on its own if you stop giving them that. So is that a concern with this kind of trial period or is that a myth? Maybe
That's a great question, and there is some nuance to that. People, duration and dose matters. There have been a number of trials looking at, for example, fertility recovery, which is more sensitive than just being able to produce your testosterone after being on therapy. Most people will recover both. The question is, do they recover to the same level they were at beforehand? For testosterone, it looks like they do. Again, unless somebody's been on for 15 years, at a very high dose, probably unlikely. Somebody who's been on for 6 months, a year and a half at a completely reasonable dose, they are very likely to recover. Same thing is true for spermatogenesis. About 95 to 99% of people that have been on exogenous testosterone will recover to normal levels. Important point there is that their levels will probably decrease compared to what they used to be, but they went from normal to lower in the normal category. So anybody that wants future fertility, that's one of my first questions. Like, are you done with kids? If your answer is no, you're not getting testosterone from me. I'm not going to play the game where we put you on, take you off, do all these things, because I do think it could potentially impact that. And the last thing you want is to create a situation where you're doing IVF or something else when you could have just waited a few years and taken an alternative therapy.
Great, thank you.
Okay. I feel like this gets into like I think this is where we all kind of get nervous and just making sure we're not missing anything. So whenever you're diagnosing, we kind of already talked about kind of what an abnormal testosterone level is, but when you do the testosterone and you repeat it, talk us through the FSH and the LH and the prolactin and the secondary workup and thinking about hemochromatosis and pituitary MRI. Just like, where does your mind go at that point?
Yeah, so normally if they have one testosterone that's abnormal, I order everything just because you guys, do this too. I'm not going to send you to lab A, lab B, lab C, lab D. Patient's really pissed. They've missed 4 days of work. Why am I getting all this? I just want my testosterone. So normally my first will be a total testosterone. If that's low, I'm ordering free testosterone, SHBG, estradiol, depending on the patient. Often ordering it though because of the, how rampant obesity is, and that can obviously influence things. Specifically, that can influence libido independently of testosterone levels. Luteinizing hormone or LH. If there's a fertility concern, I'll order FSH. If there's no fertility concern, there is no reason to get that hormone. Prolactin I get as well, even though, again, you could argue, and I have a paper on this, that the incidence of prolactin producing tumors is incredibly low and probably not cost effective. But again, if their LH comes back suppressed, I don't want to be sending them back to the lab. So it's for a matter of not having repeat lab draws. I told you I screen for sleep apnea. If they have not had a recent TSH, I will get that as well. Vitamin D, vitamin B12, if they have not had that. Luckily, most people see all of you before they see me. So they have a lot of the baseline labs, but I will get all those, especially in the people who are complaining of fatigue. In terms of ancillary testing beyond that, I think a testicular exam is super important. People come in with atrophic testis. You may be wondering what's going on here. Do they have something like Klinefelter's that has gone undiagnosed? Do they have other things that they may not even know? I see that from time to time where somebody comes in and like, man, you're here for ED, low libido and something, you're 25. Have you ever tried to have a kid like that? All of a sudden this becomes a fertility conversation as well. So I do think a testicular exam is important. Beyond that, MRIs, there are two big indications. Number one would be an elevated prolactin level. I would get an MRI. And the second would be somebody who truly is hypo. So somebody comes in with an LH that's undetectable or inappropriately low. Like your testosterone is 150 and their LH is 2. That doesn't make any sense. Something's wrong there. I would absolutely get a pituitary MRI at that point as well. Beyond that, sometimes it's pretty hard. I mean, if they have family history of things where you're looking for like hemochromatosis, I mean, you can do genetic testing. I can't say that I'm doing any kind of iron studies or anything looking for that because at some point it doesn't matter. If we see obviously central deposits versus peripheral deposits, like in their testis, it doesn't necessarily change their management from my perspective. It probably does for whoever's managing the hemochromatosis, but I don't do, workups beyond that. If there's a concern, then I do send them back to endocrine.
When I was a chief resident, I was ordering a bunch of labs for someone's hypogonadism. And I remember, like, because I ordered an iron panel and a cortisol, and I ended up sending them for stem testing. I remember one of the, one of the physicians in our group who I was covering for was like, what are you doing? Because, like, if you go on up to date, you can follow this so far. And I feel like we get so caught up as internal medicine and being like, well, that's technically inappropriately low because the testosterone is low, so that we would assume that the LH would be higher, and we kind of get caught up in this mental mind game. I feel like it's helpful to hear, like, if it's not low, it's probably not a pituitary problem.
It's very unlikely. I will tell you, I get referrals occasionally from endocrine for testicular biopsy to determine the etiology of hypogonadism. I was like, the risk of that procedure versus the information gained seems to not be congruent. I'm going to decline the software after discussing it with the patient. So again, if they're like, hey, we specifically think it's got adrenal rest tumor or something else, like, of course, but that usually should be felt on exam. That's why I do think the testicular exam is important. If you don't feel comfortable with that, again, an ultrasound would be okay too.
The testicular exam, yeah, it's just not something that we're used to because I know you're looking for a certain size and like that is the all of the difference, but I feel like I wouldn't even think about it if the FSH and LH aren't more on the elevated side.
Yeah.
I don't know.
Yeah, I mean, size, consistency, position. I mean, again, I do think, unfortunately, your guys' job is really tough. Like, you guys have to examine every body part. Like, I get very limited, some abdomen, and then, the GU system. So, I mean, the whole thing with the, looking at like digital rectal exams for prostate cancer screening. I mean, I'm glad a lot of that's fallen by the wayside, but like, if you're not doing these exams regularly and don't have a baseline, again, I'm not saying to get a scrotal ultrasound on everyone, but it is a test that gives a lot of data if there is a concern.
Okay. All right. So second testosterone came back negative. I just said secondary workup was negative for any concerning etiology. So because I just want to talk about supplementation, you've already given a really nice pearl early on, but discuss the approach to the conversation on the supplementation. My big approach is usually I'm just like intramuscular or gel, and now you have something else that's just going to blow it all out of the water.
Yeah. So my thing is, first of all, what can we do to modify what lifestyle habits you have? Would this person benefit from a GLP-1, which I don't prescribe? But would this person benefit from actually trying to figure out a reversible etiology of their testosterone deficiency? Is this being driven by sleep apnea? Is this driven by metabolic syndrome? I know you said this person specifically, there's no secondary causes, but those are things that aren't direct secondary causes that are absolutely important. And if I can convince the patient to lose weight or do something first, that is my first go-to. If I can't, which is, as you know, most of them you can't, you say, hey, why don't we do this and replace your testosterone? In my normal speech is that there are gels, there are injections, there are pellets that are implanted under the skin, there are nasal gels, there are troches, there are pills. Of all of those, the only ones insurance usually cover are either the injections or the topicals, which again, there are gels, patches, like solutions that aren't like gels that like absorb underneath your arm. The ones that are most commonly covered though are the injections and the gels. In terms of things that are generic, if nothing is covered, the injections are by far the cheapest. Most patients in my practice are on some form of injections, followed by gels, followed by the pellets. I'm training a APP right now to help me with my pellet practice because it's pretty busy and I'm the only person I'm aware of doing them. I do not think the procedure is incredibly hard. If somebody wants to learn how to do testosterone pellets, please send me an email. I'm happy to proctor you on how to do that procedure. There are some nuances in terms of follow-up, like, labs and stuff on that. But it's nice for some patients because it's only administered every 3 to 4 months. And these little pellets dissolve underneath the skin and keep relatively stable levels throughout. Usually peak levels are around 600-700, trough levels are around 250 to 300, right as the pellets are wearing off. Gels, there are a bunch of different formulations, 1%, 1.62. You guys probably will see a bunch of Androgel, which is the primary thing that gets approved by insurance. Starting dose is 2 pumps per day. Got to make sure they're doing it right. Not, some people read 2 pumps, they put 2 pumps on each side. It's usually 1 pump each side, upper arm area. Make sure they let it absorb for 10 to 20 minutes before they put a shirt on. I'm a little bit more careful, especially with the younger men with this. There have been several papers looking at the amount of it that is deposited in a washing machine afterwards. If they have kids around the house, I tell them this may not necessarily be the best option for you. Can obviously get on a loved one, pets, cause skin irritation, or the things that I say independently of all the other risks for testosterone we talk about. Injections tend to be a little bit easier if people aren't completely needle phobic. I do sub-Q injections, pinch belly fat, just like GLP. I tell them like if you're taking Ozempic or something, it's gonna be the exact same thing. I use a 25 and 5/8 needle, 25 gauge 5/8 needle. I find is small enough so they don't feel it as bad and large enough to deposit the oil. If you use a smaller needle, the oil is so hard for them to inject. If you use a bigger needle, they tend to complain of discomfort. And my dosing for that is lower. So the dosing is much more similar to that medication I talked about, Xiasted, which is literally just it's testosterone enanthate, which is a generic. The drug got approved because it's an auto injector. So it's the methodology of injecting. It's just a sub-Q auto injector. There's really no magic to it whatsoever. But their doses, if you look at their dose response curves, are very similar between 75 milligrams of intra or sub-Q testosterone compared to 100 of IM testosterone. So most of my patients are dosed on 80 milligrams just because it's easier to draw up. Because nobody, I mean, if you guys can find 100 milligrams per milliliter, great. I'm finding pretty much all pharmacies have 200 milligrams per milliliter, meaning trying to drop 0.35 is pretty darn hard for most people. So I usually dose people at 80 milligrams sub-Q weekly, which I found has decreased the rate of polycythemia I have. Nobody comes to my clinic for injections, but they can come obviously for a single teaching thing with one of my nurses to teach sub-Q injections, and I have pretty good traction with that. Complaints people will get are that some injection discomfort. If they don't get the needle all the way in, they can get some lumps or bumps from the oil. Just make sure that they're rotating sites when they're giving themselves the injections, but I find it is pretty well tolerated. You might say, well, how the heck do I measure a testosterone level to follow this up? Mid-cycle level is impossible. Testosterone cypionate's half-life is 7 days, and nanthate's is 6 days. How do I follow this? Normally, I get trough levels. So I'll tell them, don't just ignore the number. I usually get the level either the day of or the day before the injection and make sure it's not something that's like, if it's like 150 or like 200, that trough level is pretty low. That means they're probably never really in that therapeutic range. If the number's like 350, 450, it's not really a mid-cycle level. Usually I'm thinking to myself, that's pretty good. If the number's 800, make sure that they're doing okay. It's unlikely at that dose you're going to see that, but even if you do, again, their peak level probably is no worse than it would be if they were on a big slug of IM. If that level comes back at like 1,000, 1,200, they're having secondary side effects, increase, polycythemia or something, then I will dose reduce. But usually that's my starting point. Labs for steady state should occur with injections about 6 weeks afterwards. So I will usually get those repeat labs 6 weeks afterwards, and that includes the testosterone, hematocrit, and a PSA if it is relevant. The gels I usually do a month afterwards, same thing. Testosterone, hematocrit, and PSA if it's relevant. Estrogen, again, if it's relevant, but this is people that will be complaining of like nipple tenderness, breast growth, something of that nature. Or you have like, hey, my sexuality was good, it got better, then all of a sudden got way worse. Again, things I'm looking for there are again estrogen levels and sleep apnea. I see is testosterone patch available? It is. It's often not approved by insurance and has an increased risk of skin irritation compared to the other topical therapies. The pills and the nasal gels are interesting. They're dosed twice daily, and because they're dosed so frequently, they actually tend to decrease spermatogenesis less. Some people are still able to have children on these. The postnasal drip from the nasal gel has stopped me from prescribing it. I have not had a single patient who's been okay with it. And the pills, the number of times people forget to take them and the lack of it being covered by insurance and costing about $170 out of pocket per month has made very few patients take that. The injections at 80 weekly, even without insurance, are usually like $30, $40 a month with all the syringes and everything at most. What other did I not talk about? Talked about the pellets, gels, injections, lifestyle modifications, and then the two that I rarely prescribe just because the side effects and or cost is too high.
The pellets, do they get, I know you said like the gels and the injectables get covered, but what about the pellets that we put in? How much are people looking at for something like that?
Yeah, it's usually like $800 to $1,200. Most of them do get covered. A lot of them is Medicare patients. This is a very lucrative for people that do, buy and bill. Obviously, we don't do that at this institution, but that's why there's a lot of private people you may get. They're like, oh, I've been on pellets. I pay the guy $1,000. I was like, okay. Thus far, I've not had. Usually, I will cancel the pellet procedure if the person's like, hey, this is too expensive. Like, well, fine, we'll find something else. And the only people that I have a lot of people in my practice that have prostate cancer or have treated with prostate cancer on testosterone, which is a 2 hour long lecture that I have. But those patients I will not do pellets on because they're like very hard to remove if you ever had to remove them. Can you clarify when you check the follow-up T levels? Now, yeah. If you're doing intramuscular testosterone every 2 weeks, yes, you check mid-cycle levels. That's the gold standard of checking. If not, the levels I normally check after someone's in steady state after 6 weeks is the day of the day before weekly injections or 4 hours after a gel application after steady state, which is in about a month. Commercial insurance occasionally covers Xiasted. I have a lot of patients in my practice on Xiasted. Things you need to do before you get it approved would be to fail one or more formulations and document a reason for that, either poor absorption, needle phobia, something of that nature. I mean, they have a pre-templated thing. If you're interested, I have an epic smart phrase I made that basically you can just check a few boxes and somebody could print it out and send it in so you have to fill something out.
Do you ever check like do you ever check a peak level like the day after the injection? I mean, I don't know, because like that makes me nervous just checking just because it's different from my normal practice.
Yeah, I don't check peak levels. I don't know how they work, honestly. All I
Yeah.
know is that the peak levels have been associated with some of the side effects. We really don't have a good understanding. I mean, I was a personal trainer in another life, and a lot of exercise physics literature talks about skeletal muscles basically having a much higher receptor saturation point, which is exactly why these peak levels, the people that do injections tend to have much better skeletal muscle gains than people on gels or something. So there's a reason why some people may prefer injections, but it is for that peak level due to the fact that that receptor has a much higher saturation point. Are you sure? I mean, no, I'm not aiming for morning testosterone levels. I'm aiming for that needs to be appropriately timed. So if you inject on Fridays and you're doing weekly injections, I want it Thursday or Friday. I don't care about morning. I don't care if you injected as long as you're not, getting your blood drawn right from where you injected from, which they shouldn't be since it's sub-Q. Like some people are like, oh, I just injected myself. The level's gonna be really high. I was like, no, 48 hours later it's gonna be really high. Right now it's not.
Hmm. And is it just because, so not going for the morning one, is it just because you've already messed up their normal physiology? Like
Correct.
it's just coming down on its own. Okay.
Correct.
Um, shoot.
Follow-up testing. Follow-up testing outside of the immediate follow-up. I get testing on people every 6 months. Guidelines would say if people have been stable, you don't need to test people more often. And guidelines would also say that you don't need to keep testing PSAs if it's been stable. I don't think our literature is all that great in that space. I do tend to do it anecdotally. I get an H&H instead of a CBC though, just to try to minimize the amount of tests, like the amount of results people get. Hopefully it's less expensive here, but at Northwestern it was ironically more expensive because the chip they ran for an H&H than a CBC. But yeah, I would get that usually every 6 months.
Okay.
Is there a role for phlebotomy? Yes. Things that would make me send somebody to heme would be somebody who has a low dose and has an inappropriately high response that is negative for sleep apnea. Person's on 80 weekly, hematocrit goes from 44 to 48 to 54, and they don't have sleep apnea. That person's going to heme. If I don't have a good explanation, I'd send that pretty quickly. If somebody's on a higher dose and their levels go up, we back the dose off, their hematocrit drops. I'm not going to send that person to heme. Levels that are dangerous. If you look at some of the polycythemia literature as well as some of the hematologic malignancies, 54 is we're not giving you anything. You are getting phlebotomized. We are repeating it and we can restart it afterwards. 52 is we can try to dose reduce to prevent you from getting to 54. And 50 is like, hey, this is a problem. We need to monitor this closely. Those are usually my thresholds. And I just noticed Tiananthe, yeah, the 28-day injection. No, I don't. Again, just because the peak levels tend to be higher in the longer frequency injections. I think our understanding of the peak levels is pretty poor, and that formulation is not quite as good as the undecanoate, which is both a VEED, which is that 3-month long injection, and it's also the same formulation as the oral pills. They're all undecanoate. But I do like an anthate. I do like an anthate a lot. It's just very hard to get. Most people you'll find is cypionate. One last thing, propionate, do not use. It has a very high incidence of peripheral edema. Its half-life is 48 hours. It was pretty much only used in the bodybuilding area. You probably won't be able to get it, but if somebody comes in asking for like triple test or test probe, I would tell you that there's no good reason to ever use that drug. Not from a medical standpoint. Is there an age limit where you would suspect a secondary cause? Honestly, not really. I think it can happen at all ages. People with infiltrative testicular cancers, I could think of younger people which are more likely to get that. Older men obviously having again like hemochromatosis or something else manifest then. Yeah, I don't think there's a one size fits all model there. It's a good question.
I feel like the questions could go on forever. We are like totally at time. This has been just like enlightening. I can't thank you enough for making the time in your schedule to come talk to us. We will almost certainly be reaching out about something else in the future because this is just like this is as good as it gets for these things. So please let us know if you have any other questions for him. I can help filter thing over to him for any other questions. But awesome interview. People are loving it. Thanks, Jake. I appreciate it.
Awesome. Thank you very much for having me. You guys have a wonderful day.
Yeah, sure.